Okay, so this is antiarrhythmics, class 1C. Examples would be flecainide, nadine, propafenone. The acronym would be Can I have fries, please? Can I have fries, please? C, okay, and flecainidine and propafenone. Mechanism significantly prolongs ERP and AV node and accessory bypass tracks. No effect on ERP and Purkinje and ventricular tissues. Minimal effect on AP duration. Clinical use: SVTs, including atrial fibrillation, only as a last resort in refractory VT. Ventricle fibrillation. Ventricle fibrillation. Pro-arrhythmic, especially post-myocardial infarction, contraindicated. IC is contraindicated as well in structural and ischemic heart disease. Then we have antiarrhythmics beta blockers, class 2, metoprolol, propranolol, uh, esmolol, atenolol, timolol, and carvedilol. Beta blockers, they decrease your SA and AV nodal activity by decreasing CAMP, decreasing calcium currents, suppress abnormal pacemakers by decreasing the slope of phase 4. AV node, particularly sensitive, so you have an increase in PR intervals. Esmododol is very short acting. SVT, ventricular rate control for atrial fibrillation and atrial flutter is the clinical use. Adverse effects, impotence, exacerbation of COPD, asthma, cardiovascular effects, bradycardia, AV block, and heart failure. Central nervous system effects, sedation, sleep alterations may mask the sign of hypoglycemia. Metoprolol can cause dyslipidemia. Propranolol can exacerbate vasospasms and prinzmetal angina. Beta blockers, except the non-selective alpha and bravo antagonists, carvedilol and labetalol, cause unopposed alpha-1 agonise if given alone for pheochromocytoma or cocaine toxicity. Treat beta blocker overdose with saline, atropine, or glucagon. Antiarrhythmics, potassium channel blockers, class 3. Examples would be amiodarone, ibutylidine, dofetilidine, and sotalol. And the acronym would be AIDS, AIDS. Mechanisms that increases AP duration, increases ERP, increases QT intervals. And then we have atrial fibrillation, atrial flutter, ventricular tachycardia. That's clinical use, typically using amiodarone and sotalol. And some of the adverse effects with sotalol, Torsades de Pointes, excessive beta blockers. Remember to check PFTs, LFTs, and TFTs when using amiodarone. Amiodarone is also lipophilic and has class 1s, 2, 3s, and 4 effects. And ibutylidine, Torsades de Pointes, amiodarone, pulmonary fibrosis, hepatotoxicity, hypothyroidism, or hyperthyroidism. Amiodarone is 40% iodine by weight. It acts as hapten, corneal deposits, blue-gray skin deposits resulting in photodermatitis, neurological effects, constipation, cardiovascular effects. Arithmetics, calcium channel blockers, verapamil, diltiazem, decreases conduction, increase velocity, increase ERP, increase PR interval, prevention of nodal arrhythmias such as SVT, rate control, and atrial fibrillation. Adverse effects: constipation, flushing, edema, cardiovascular effects. And other arrhythmias, adenosine increases the potassium out of cells, hyperpolarizing the cell and decreasing current, decreasing AV node conduction. Drug of choice in diagnosing and terminating certain forms of SVT, very short acting, 15 seconds. Effects blunted by theophylline and caffeine. Both are adenosine receptor antagonists. Adverse effects include flushing, hypotension, chest pain, sense of impending doom, bronchospasms. Magnesium, Mg2, effective in torsade de Pointes and digoxin toxicity. Ivabradine, selective inhibition of funny sodium channels, prolonging slow depolarization, phase 4, decreasing SA node firing, negative chronotropic effect without inotropy, also reduces cardiac oxygen requirements. Chronic stable angina in patients who cannot take beta blockers, chronic heart failure with reduced ejection fraction. And adverse effects for ivabradine is luminous phenomena, visual brightness, hypertension, and bradycardia.